Good morning, everyone. I know that we are running short of time. So I will be briefly discussing our experience with immunotherapy in the neoadjuvant settings in people who have locally advanced HCC with with venous tumoral thrombosis without extrahepatic disease. Does immunotherapy helps in more number of patients having a successful downstaging? We all know that HCC continues to be a major cause of morbidity and mortality in patients with end-stage liver disease. And the checkpoint inhibitor-based therapy has radically defined overall survival in this group of patients. And we wanted to see the safety and efficacy of this checkpoint inhibitor-based therapy in potential liver transplant candidates who did not have extrahepatic disease but only had vascular invasion. So this is a retrospective analysis of patients with advanced SSC who were not candidates for upfront transplantation because of either their disease extent or previous unsuccessful downstaging. And they subsequently received further downstaging modalities or immunotherapy. Of total 45 patients who were treated like this, 8 patients who got partial response of the parenchymal tumor, that is SCC, and had what we have tried to use the term as complete resolution of the vascular tumoral thrombosis, complete CR of VTT, with either immunotherapy alone or a combination, that immuno plus minus ablative therapy. So this is our institutional protocol. If the patient is a candidate for upfront transplantation, he goes for surgery. If there is extrahepatic disease, you manage with base supportive care with child C patients. In the middle, if there is extrahepatic disease, you try to see whether the patient is ATEEZ eligible or not. That means you rule out autoimmune causes. You look for varices and then choose either ATEEZ-BAVE or lenvatinib. And if there is no extrahepatic disease, then obviously you try to downstage them. The primary tumor by either a tear or TACE, and portal vein tumor thrombosis by radiation. And you can probably use ATEEZ-BAVE also as an add-on. If there is successful downstaging, the patient goes for transplant. If there is suboptimal downstaging, maybe you can repeat one of the modalities, like repeating an SBRT for the VTT, or an ATEEZ-BAVE add-on can be considered. And if there is successful downstaging, then the patient can go for transplant. So total, it's a small experience, total 8 patients who were treated with such modalities. Mean age was 56 years, all were males. The predominant etiology was viral. 75% of patients had viral etiology. The severity of disease, mean CTP was 6.7 plus minus 1.3, median male was 11. Most of our patients had a grade 2 LB. Almost 50% of them had required endotherapy in past. 3 required EVL and 1 required glue injection for frontal varices. And after documenting that they are at not risk for further bleed, they were started on IO-based therapy. Almost all of them, 8 of them had vascular invasion, none of them had extrahepatic disease. Previous downstaging was attempted in 5 patients, 62.5%. The number of cycles of therapies were 3 to 4, and 7 patients received ATEEZ-BAVE combination, and 1 was from the older pre-ATEEZ-BAVE era, which received nivolumab. All these 8 patients had complete response of the vascular tumoral thrombosis. So, but not every one of them were transplanted. Few of them were not keen for transplant, and one of them were lost while waiting for the cooling off period. So I tried to divide them into 2 groups. The ones who were treated with immunotherapy alone without downstaging. So there are 3 patients as such. The first we can see is had a HBV-related cirrhosis with right hepatic vein tumoral thrombosis and was treated with ATEEZ-BAVE, 3 cycles. The baseline AFP was 2,58,000. The patient had to be switched on to lenvatinib because he developed grade 4 chili, that is checkpoint-related liver injury, which responded with methylprednisolone, and subsequently that patient was switched to lenvatinib. So he had complete response, PR of HCC, and complete response of HVTT at 3 months, and at 6 months there was complete response of the primary tumor also. But somehow the patient was not keen and was managed conservatively. He is doing well, and since the start of immunotherapy, it's almost 3 years, 33 months now, and we are following him up. So this is the kind of survival we are seeing with these kinds of modalities. The second patient was again HBV-related cirrhosis with RPVTT, received 6 cycles of ATEEZ-BAVE, and then had complete response of PVTT. He was planned for a transplant, but while waiting for the 2 months washout period, the patient developed sepsis and subsequently succumbed to it. The third patient also similarly had received 9 cycles, had a stable disease, but there was complete tumoral response, and the family was not keen for transplant, so he was also doing well for almost 2 years and subsequently had decompensations and death. So this is a group of 5 patients who received a combination of IO and other locoregional therapies. So all of the patients had a criteria, the tumor was within the institutional criteria, any number, any size, without extrahepatic disease, and all of them had, with or without, with the combination of TARE or SBRT, had stable disease of the HCC and complete response of the portal vein tumoral thrombosis. 4 of them patients received LDLT with a median period of 4 to 7 months from the last dose of checkpoint inhibitor to transplant, and all of them who were transplanted, no one had on the explant a portal vein tumor. All the portal veins were free of tumor. We have follow-ups ranging from 2 to 10 months. One patient, the third patient, which you can see, had severe GI GVHD, which were treated with anti-TNF-based therapy and had subsequently had a death because of unrelated cause, likely and sudden cardiac death. And in one patient only, we had an HCC recurrence 8 months after transplant, for which he had been started off lenvatinib. The 5th one is awaiting transplant after the cooling off period. So to conclude, immunoablative therapy, that means combination, is useful in downstaging in patients who have advanced HCC and PVTT. Immunotherapy alone can be useful as a downstaging modality in select group of patients. However, there are many questions which are open questions which are unanswered, like which can be the ideal candidate based on the child status, ALB score, etiology of liver disease, varices, genomics, and what kind of regimen is ideal, IO alone or with combinations with TKIs and the sequencing. So this is the latest meta-analysis which was published a month ago, and around 91 patients who had pre-transplant IOs. So HCC recurrence was only in 10%, rejection was in around 26%, and none of them had a graft loss because of rejection. Thank you.